Welcome to this Beyond Zero e-learning module, which is part of the catch-up modules from the Wits RHI Advanced HIV and TB course. This is the second part of 2 on pediatric HIV testing, and we'll be covering initiating children on HAART. So in our first module, we outlined 4 key strategies to optimize pediatric HIV outcomes. And in this particular module, we want to look at increasing the uptake of our cotrimoxazole initiation and early initiation of HAART in infants and children. Cotrimoxazole initiation has been with us for many, many years and is one of the key aspects of care. Cotrimoxazole initiation in children are key to long-term survival, as one of the major causes of death in our infants is PJP, or pneumocystis jirovecii pneumonia. And usually children already become ill by the age of 2 to 3 months, and that is even before the CD4 count is affected. So it's very important to make sure we get our babies on cotrimoxazole early. Here's a few things about Bactrim that we're aware of. Hypersensitivity is an issue. Luckily, we see it very rarely in our children. And if we do have children that do have an adverse drug reaction to cotrimoxazole, we can use dapsone in its stead. So let us quickly run through those key recommendations for cotrimoxazole prophylaxis. So remember, we start all our HIV-exposed babies on cotrimoxazole between 4 and 6 weeks of age. We can't start it before 4 weeks because Bactrim is actually potentially toxic to the neonate. And we normally start at 6 weeks because that is when they arrive for their first EPI visit. Remember, we no longer do a PCR at 6 weeks. We're only going to do the next PCR at 10 weeks. So all of our HIV-exposed babies is going to be on Bactrim between 6 weeks of age until they've got that 10 weeks PCR base back. In the guidelines, there's a very complicated table that goes through it all in very much detail. So we're going to cover the 5 main scenarios you need to remember for CTX prophylaxis. Firstly, we're going to start all our littlies at 6 weeks of age, regardless of if they're on formula or if they're being breastfed. And they're going to need to stay on Bactrim until you get your PCR test back, quite often only at 10 weeks. Once the PCR test comes back and they're HIV negative, if the baby is formula fed, it means the baby is no longer potentially going to get HIV, and we can stop the Bactrim. If the baby is HIV negative but the mom is still breastfeeding, it means that there is still small risk that the baby might convert, and therefore we will continue the cotrimoxazole until after the baby has been weaned for 6 months. PJP is one of our biggest complications in babies who develop HIV early. If the child is diagnosed with HIV, then all of them must be on cotrimoxazole until 1 year of age. If the children are older and they're between the ages of 1 and 5, then they still qualify for Bactrim if the CD4 is under 500 or under 25%. And similarly, if you want to stop the cotrimoxazole, you would wait until the CD4 count is over 500 or over 25%, at least 3 to 6 months apart and 2 different occasions. And once they're over 6 years old, we use the same cutoff as for adults at the moment, where the CD4, if the CD4 is under 350 or they're stage 2, 3, or 4, we would like them to be on cotrimoxazole. If they're stable on ART, the CD4 is over 350, then you can consider stopping it. But children who has had or been diagnosed with PCP or PJP, as it is now called, at any age before the age of 5, we will continue the cotrimoxazole prophylaxis until they are 5 years old. So once we have our babies on Bactrim, the now big priority is finding those children who are HIV positive and getting them onto ARVs. And we are going to be using the IMCI overview of starting ART. Quite often healthcare professionals panic when they have to put children on ARVs. We are not having much problems in getting all our adults on ARVs, but people always feel slightly nervous when they have to initiate a child. And the IMCI outlines 6 very clear steps that can help accompany a nurse or a novice doctor into getting children onto ARVs. Here's an overview of what the page in the IMC looks like. It's already a little bit out of date with the new UTT guidelines that's just come out there at the moment. And you can see it gives you a nice step-by-step approach to initiating ARVs in children. Step 1 and 2, we've covered step number 1 already in the previous module on HIV infection. I'll say 1 or 2 more things about it, and we'll talk very quickly about eligibility. But the step 3, 4, 5, and 6 we'll cover in more detail today. So deciding about the caregiver, deciding if this should be a nurse or a doctor-initiated patient, accessing and recording certain baseline information on your child, and then initiating your ARVs. Step 1 is about deciding if the child has HIV infection, and please also keep in mind that the child is in a larger context. So if this child has HIV infection, there might be a sibling that is also infected. Also be very careful to not only test those children who look ill. Take a good history, do your growth monitoring, do your measurement, and we want to actually find opportunities to test children. We know there's still many children who fall through the gaps. PMTCT, we're getting better and better at testing all our exposed infants, but also if there's any request or if we have got families, complicated families, death of the mother and father, those all qualify for HIV testing. Our primary healthcare clinic should be having a high level of suspicion. IMCI is very clear about what type of symptoms we should look for. And for doctors in our pediatric inpatients, in our TB clinics, our children we see with abuse, and also for our rehab teams, we all need to be aware of provider-initiated counseling and testing. Very important for our foster children and our orphans. And we therefore have to almost ask ourselves the question, is there a reason why this child does not qualify for an HIV test? About eligibility, there used to be a whole set of slides on why it is important to start children early, that it's important early diagnosis, early treatment, better outcomes. But we now have universal test and treat, which means that all children, regardless of CD4 count and age, qualify to be started on ARVs. And it's just a matter of how urgently you do it, whether within 1 or 2 weeks, that actually has a differentiation. I'll just briefly mention the Cher Trial. For those of you considering to the diploma, it might be good to be aware of this. This was a huge trial where they looked specifically within South Africa on whether we should be starting children earlier or later on ARVs. And it is no debate that early ARVs save lives, especially when children are concerned. So now we have the family in front of you. We've got a caregiver in front of us, not even necessarily the mother. And of course, the caregiver is the one who's going to be responsible for getting the ARVs. So there's very clear guidelines on making sure that there is at least one identifiable caregiver who is able to supervise the child or administer medication. And the important key question is who wakes the child up in the morning and who puts the child to bed at night. So the caregiver who is sitting in front of you might not be with that child every day of the week. And you want to know that there's at least one caregiver that can take responsibility throughout the week for the child's treatment. It is very, very helpful to involve other adults within the house, both to support the caregiver, to help remind the caregiver, to help assist the caregiver. But this is only a recommendation. We can't say, no, we're not going to start ARVs because you're not ready to disclose. If you've got one caregiver who's willing to take responsibility, we're going to start those ARVs. And there's a few things you can consider when you have that caregiver. We've talked about who wakes the child up and who puts the child to bed. What is the HIV status of the caregiver? What is the health of the caregiver? Has the caregiver disclosed to other people in the household? And how capable is this caregiver to manage numbers and syringes and instructions? There's going to be various bottles with various different instructions. And is it easy for the caregiver to get to the clinic? And most importantly, is the caregiver willing to give the ARVs? In the IMCI, they make the differentiation about whether the child should be initiated by a nurse or a doctor. A lot of clinics, the nurses don't feel confident in initiating children at all and would rather refer to the doctor. And I think the IMCI is partly trying to encourage nurses to initiate children when they can. Our very successful PMTCT program is part of the problem. We're seeing much less children being diagnosed with HIV, and so nurses have much less experience in initiating children. And there's a few basic contraindications for NIMART for a nurse to initiate. And in the IMCI, there's very specific danger signs. So a child obviously is very ill, and these danger signs, or all children need to be admitted to hospital, is not going to be started by a nurse on ARVs. But very important, children weighing less than 3 kilograms and neonates must be initiated by a doctor. Please see our e-learning module on neonatal ART that identifies the differences between initiating children and neonates on ARVs. For children who are breathing fast, children who we are considering of TB, also needs to be referred to the doctor. It's not easy to diagnose TB in children, and both over and under diagnosis is possible, and it's better that the doctor helps with that. So great, we've got our caregiver all ready and set up, and we now need to assess and record baseline information about this child. So there's some very basic investigations we're going to take. It's not necessary to wait for the results of your investigations before you start the children on ARVs. Our ARVs currently are very safe, and we can therefore safely initiate them while we wait for the results to come back. As mentioned in our HIV testing module, we're going to confirm with the PCR we do not do baseline viral loads. We do hemoglobin in our children mainly for prognostic reasons. It gives us a bit of an idea of the staging of the child and how sick the child is. We need to do a lipid profile as a baseline because we're going to be starting the child on a PI for our littlies under 3 years old. We're going to do a CD4 count to be able to also for prognosis and also to identify those children who are at higher risk and which children need Bactrim when they're a little bit older. But interestingly, because this is different than the adults, if you're going to put a child on both TB treatment as well as ARVs, they do recommend an ALT. But there are other things we need to write down or assess apart from just the blood tests. And sometimes the list of all the little things we look at is so long, I think everybody just ignores all of them. So I've divided it into 3 main areas. And every time you see a child, you just think dog. 3 main things that we have to check at baseline and at every single visit. The D stands for developmental assessment, often forgotten, and it's very quick to ask the mother, is she worried about the child's development, and to check a few basic milestones for that particular child's age. Have a nice little poster on your wall that can help remind you on what we expect children to do at different ages. And remember to ask about school and how the child is managing at school if the child's a school-going child. So is the child at the right grade for their age, for example? The O stands for opportunistic infections. Very important just to look clinically where the child is. And remember, we have to do a WHO status on our child. That gives us a really good idea of prognosis and how sick the child is when we start them on ARVs. We're obviously going to screen for our main OI, such as TB. Remember about deworming in our children, forming our regular deworming in our HIV children, very important. And ask about what's happening with immunizations and discuss that with your parent. And then the G is for growth and nutrition. What is happening in our clinics is I think all our children are certainly weighed. What is not happening is interpretation of those indicators. And any child that you see, you need to be able to say with confidence, what is the Z score for this child for weight? What is the Z score for height? And what is the Z score for weight for height or weight for length? Or either using a MUAC or a BMI. So we want to know if the child is underweight, we want to know if the child is stunted, and we want to know if the child is wasted. And you cannot do that if you don't plot. This is also to remember chatting about their feeding choice. Are they formula feeding? Are they breastfeeding? If they're older, how eating and feeding is at home. If you remember these 3 aspects, baseline and every visit, you will cover most of the important things that needs to be covered during the pediatric assessment. So now we are ready to start our ARVs. Just a quick reminder that most children we will start within a week or to 2 weeks after diagnosis of the HIV, but there are some children we want to fast track. So all children under 1 year of age, we want to start on ARVs within a week. Children with MDR and XDR TB needs to be prioritized for ARVs, but the actual interval of how soon we would start them on ARVs will depend on the MDR TB consultant. Any child with stage 4 disease, we would also want to start within a week. And any child where the CD4 count is under 200, or we would use the percentage, the CD4 percentage is under 15% in children under 5 years of age. So let us look at some of the drug formulations and specifically around side effects of issues of the different drugs that we have available. These are our main classes of drugs. I'm not going to spend a lot of time on them. And the main three groups that we have within the public sector is our NRTIs, our NNRTIs, and our PIs. Now, our nucleoside reverse transcriptase inhibitors for children, the most common drugs we are using is Abacavir, 3TC, and AZT. Of our NNRTIs, are non-nucleoside reverse transcriptase inhibitors. It's usually Efavirenz, unless we're using nevirapines in our neonates and our prophylaxis. And then PIs, we have Lopinavir, Ritonavir, and for the older children, we've got Atazanavir. But there are new classes out there, and certainly the integrase inhibitors are part of our third-line regimen now, and there are some children who's already having an integrase inhibitor as part of their regimen. If you look at our first-line regimen for children, it's relatively simple. So all children under 3, we will combine Abacavir, 3TC, and Lopinavir, Ritonavir, or if they're still under 10 kilograms. So this has mainly got to do with our ability to get good pharmacokinetic data on children under 3 years of age. They all seem to digest the Efavirenz differently, and it's been very difficult to get good dosing levels for that age and for that weight. So a child has to both be over 3 years old and over 10 kilograms for us to use Abacavir, 3TC, and Efavirenz. Very, very important. If a child was started on Abacavir, 3TC, and Lopinavir, Ritonavir, they will stay on that regimen at the moment, probably for life, unless they are failing. There's not at the moment a recommendation of switching those children to an Efavirenz-based regimen. If you have children who is on D4T, we want to get them off the D4T, but very importantly, only if the viral load is suppressed, you would switch the D4T to Abacavir. The recommendation and the guideline for children who are still on DDI is to switch the DDI to Abacavir. 3TC is also an option. I would discuss those children, but we rarely see children who are still on DDI in with the current regimens. The dosing chart that's still being used at the moment is the drug dosing chart for children 2013. Make sure this is the one you have on your desk. It includes the Abacavir 60 milligram tablet and the Lopinavir, Ritonavir baby tablet, the 100/25 milligram tablet. It also gives options for once daily dosing for Abacavir and Lamivudine in children once they weigh more than 10 kilograms, which is very useful for a child who's on Abacavir, Lamivudine, or Efavirenz. It means they can have their treatment once a day. Just make sure that they are actually able to manage the size of the tablet. So if you decide, great, we're going to give them a single 150 milligram tablet at night, make sure they can actually manage that size tablet. So if you look at our basic 2 regimens, there's Abacavir, Lamivudine, Lopinavir, Ritonavir. That's our under 3s. And then Abacavir, Lamivudine, and Efavirenz. That is for our over 3-year-olds. Let us start with Abacavir. And with Abacavir, there's always a concern about Abacavir hypersensitivity. Abacavir has been great because it's a once daily dosing. And now with the 60 milligram tablets, it's relatively easy to give and the solution is fairly palatable. But Abacavir hypersensitivity has been a concern. And we have to know how to identify it, even though it's quite rare in our black children. What's important with Abacavir hypersensitivity is that it's linked to an underlying genetic predisposition. And so therefore, children who are going to develop it will develop it within the first 6 weeks of starting Abacavir, and they would have a skin rash. But it's not a skin rash only. The skin rash is accompanied by systemic symptoms, which can be 2 or more of any of the following sets. So firstly, the child might have a fever, or the child come in with a bit of a gastroenteritis picture, nausea, vomiting, diarrhea, abdominal pain. Or the child might have a myalgia or a severe fatigue and look quite sick, or tiredness. So you're having a child who's got a rash but who also has other sicknesses, and it's within the first 6 weeks of starting, and the symptoms are not going away. As a matter of fact, every time the mom gives a new dose, the symptoms seems to be getting worse. And that whole picture makes you very suspicious about Abacavir hypersensitivity. If you decide to stop the Abacavir because you're suspecting hypersensitivity, you are not allowed to ever re-challenge because of the high level of mortality. And so the decision to stop Abacavir is quite a big decision, and I would always do it in consultation with a colleague or an expert. Here's some pictures of the rash. It's a really vague maculopapular rash. If Abacavir has got a rash and they don't have any fever and they're otherwise clinically well, that's also not a reason to need to stop the treatment. So a few key points about Abacavir hypersensitivity. They do like to ask this in the exam, the actual gene that it's associated with. It's called the HLA-B5701. There are other genes as well, but that's the most common one. And it's relatively rare in our African patients. Only about 0.2% of African patients will get Abacavir hypersensitivity. And there's therefore quite a big ethnic difference. So if you're seeing a Caucasian or a colored or an Indian child, as you might do, for example, either in Cape Town or Durban, you would be more suspicious of Abacavir hypersensitivity. And it's part of the delayed hypersensitivity response reactions. One can do lab tests. Usually by the time your lab tests are coming back with positive, for example, liver enzymes or leukopenias or thrombocytopenias, the child's very sick. And you certainly would have had to have stopped treatment by now. X-ray is generally normal if they do have respiratory symptoms. Your treatment of Abacavir hypersensitivity is stopping the treatment, and this is the most difficult decision. A rash on its own is not an indication to stop your treatment, and you can happily treat those with antihistamines and maybe a bit of steroids for a short course. But if there's any systemic symptoms, then you have to stop the Abacavir, and you cannot reinitiate. Matter of fact, in some of the studies where they looked at re-challenging children who had a hypersensitivity reaction, there was immediate life-threatening reactions in about 20% of those. In children where they were stopped for Abacavir and there wasn't hypersensitivity, it's very rare to see a child suddenly developing a hypersensitivity if they are restarted. So it definitely has to do with this genetic predisposition. In America, they screen all the children for the HLA-B5701 before starting Abacavir, but we do not do that in South Africa because of the very low prevalence. Still under your NNRTIs, the only other major side effect that we need to take note of is the lipoatrophy that we've typically seen on our patients on D4T and DDI. Both drugs are no longer used much, and so hopefully this should be much less common. Our other very popular drug that we are using for children of our NRTIs is our 3TC or lamivudine. And 3TC and lamivudine is a lovely drug in our children. There is reported of headaches and dry mouth, but actually it's very, very well tolerated. And just to note that amitriptyline is pretty much for practical purposes exactly the same. And that's quite important with some of the combination tablets we are using in our adolescents. But FTC is definitely a bit more rashy. We see more skin reactions and hypersensitivity than we have with the lamivudine. And then our other huge drug that we are using is our Lopinavir, Ritonavir, in our under 3-year-olds. And this is probably one of our more problematic ARVs in children use. And this is not because it's not a good ARV. It's a great drug in terms of suppressing viral load and getting good outcomes. It's robust. It's got a nice high genetic barrier. But unfortunately, we have to give it twice a day. And the adult tablets is very large, so we sometimes end up keeping the children for quite a long time on the liquids. There is now a pediatric tablet, which is a little bit smaller. But they also have side effects. So we see diarrhea and nausea and vomiting, luckily less often in the children than we see it in the adults. You can see dyslipidemia in children. If you have an increased cholesterol or triglycerides, discuss that with a consultant. Much more difficult to decide what to do with those and at which stage we would consider that to be a problem. It can increase LFTs, but it's rarely a cause of DILI. But probably the biggest issue with our children is the fact that it tastes absolutely terrible. And this is due to the ritonavir that makes it extremely bitter. And you have a very bad aftertaste of this ritonavir. Various tricks one can use to try and help people, your parents, with getting lopinavir, ritonavir into the child. The most important thing is to make sure that we've counseled them well before the child ever tastes that Kaletra for the first time. Your goal is to never, ever, ever let the child taste lopinavir, ritonavir. And you can do that by, for example, recommending the mother puts peanut butter in the child's mouth. Peanut butter is quite expensive. A lot of parents don't necessarily have that in the house every day. If you've got children who are still on a multivitamin syrup or a cotrimoxazole syrup, you can actually mix it with a syrup. That's a very effective way in your children early on in treatment, which you are still using other syrups. And you can also use something like juice that straight after the child has had the lopinavir, ritonavir, you wash it down with juice, for it's the aftertaste that is particularly vile. And we've mentioned the big tablets, and then the other big problem is that lopinavir, ritonavir significantly interacts with rifampicin, and we're actually going to speak about that in the next couple of slides. So also important, because the tablets are so big, there's a temptation to try and crush them. And an actual study done in 2011 showed that when you crush the big lopinavir, ritonavir tablet, it significantly reduces the lopinavir and ritonavir exposures. So the use of crushed tablets must be avoided. Ritonavir on its own is also available, and you'll actually see it on your dosing chart. And this is when we use it for boosting. So I've mentioned earlier that when you use rifampicin with Kaletra, it can be a disaster because your rifampicin massively reduces the dose of the lopinavir side. So you need to boost the lopinavir, and you can do so by boosting it with extra ritonavir. And the dosing of that extra ritonavir is on your dosing chart. The challenge is all the side effects I've already mentioned of the lopinavir, ritonavir is actually caused by the ritonavir. It's that which is so bitter. It's the one that causes the elevation of the LFTs. It's the one that causes the nausea and vomiting. It also has an extremely short shelf life, and it's probably one of the reasons why most pharmacies don't routinely have ritonavir on their shelves. If you know you're going to be putting a child on TB treatment with ARVs, you need to think ahead a little bit and make sure your pharmacy starts ordering in. So our third group to cover is our NNRTIs, and Efavirenz is the one we most commonly use in our children over 3 years old. And it's a fairly nice ARV. It's once daily, comes in tablets forms, and it's known for its persistent central nervous system toxicity, which is unfortunately much more uncommon in children than there is in adults. And in adults, we are very aware of abnormal dreams, depression, mental confusion, but we've got to watch out with our children because, for example, hyperactivity or behavior changes can be due to the Efavirenz and is sometimes missed. And we often miss depression in our teenagers on Efavirenz. So our contraindications is psychiatric comorbidity, very rare contraindication in our children, and obviously if they've not tolerated the Efavirenz in the past. But generally most children tolerate Efavirenz, and we use Efavirenz widely in our older children. So at some point, the question also always gets asked, at which point can we start using Tenofovir? Because if you can put a child on Tenofovir 3TC and Efavirenz, they can go on to the once daily dosing. And very important, we're not going to switch our children who are on Abacavir 3TC and Lopinavir, Ritonavir. This is only for our children who are on Abacavir 3TC and Efavirenz. And there are 3 very important criteria. They must be over 15 years of age, they must be over 40 kilograms, and they must have an EGFR of over 80. And you can only calculate that EGFR if you're actually doing the creatinine clearance calculation, because the EGFR formula used by the NHLS will only tell you if the creatinine clearance is over 60. Very, very important also is you cannot do a switch unless the viral load is LDL. So the child must be old enough, heavy enough, kidneys must be in good state, and the bile load must be LDL before you do a single substitution. If children are under 16, there's actually a more complicated formula, or not complicated, just a different formula for calculating your eGFR, and that will be for your 15-year-olds where you are considering putting them on tenofovir. And then the last class is your integrase inhibitors, and that is raltegravir, probably more relevant dolutegravir now, as that is now suddenly also become part of our third-line regimen, and we can use it in children from 2 years and up. Also twice a day dosing, and is generally fairly well tolerated. So how do we combine an ARV regimen? So what we call highly active antiretroviral treatment means that we are adding always a combination of 3 drugs. There's usually a backbone of 2 NRTIs, so either Abacavir and 3TC or AZT and 3TC, and then we need to combine it with a very powerful drug. And both our NNRTIs and our PIs are extremely powerful classes of drugs. So that's why we would either use it then with Efavirenz, or we would use it with Lopinavir, Ritonavir. And it's a very simple principle underlying all of the design of our first and second line regimens. There is a few new drugs that's being tested, and we will see how that affects our regimens in the years to come. On children, we have to talk about ARV dosing because our doses must be adjusted for weight as children grow. And to make it simple, they have created these standardized weight tables. Otherwise, it can get very complicated to actually calculate your exact dosing per weight or per body surface area. Very important just to remember is that children must be weighed every 3 months. A weight once a year is not good enough. And that the ARV dosing chart is only for children once they are over 3 kilograms and preferably over 6 weeks to 3 months old. There are scenarios where we might want to change treatment, toxicity being the biggest reason why you would consider a single switch. Remember, viral load must always be suppressed before we would consider doing a single switch of a drug. If it's quite an urgent toxicity, you would discuss that with a consultant. Treatment failure, we are covering in a separate presentation on treatment failure in children. Sometimes drug interactions might necessitate us to change treatment, but quite often we will try and find drugs that are compatible with that regimen, for example, in epilepsy. I just want to run through a few special circumstances of prescribing that is important to remember, and that is to do with rifampicin and Lopinavir, Ritonavir, which we already mentioned early, HIV and epilepsy, post-exposure prophylaxis, and neonatal ART we will not be covering in this presentation. Please see our separate e-learning module on neonatal ART for more details on that. So we often have children who diagnose with TB and then start on ARVs, or children with ARVs who then develops TB, but more often it is through the TB that we actually end up finding out the child's got HIV. If we've started TB treatment, we want to start ARVs within 2 to 8 weeks, and if the CD4 count is fairly good, over 15%, for example, and the child's fairly well, one can tend to wait more towards the 8 weeks for starting the TB treatment, simply because of the massive drug interactions between the Lopinavir, Ritonavir, and the TB treatment. If the ART is started first, double check your ARV regimen to see what we need to do. If the child's on nevirapine, we can't use nevirapine with our TB treatment very safely. If there's Kaletra, we need to boost. And what caused all of the alarm was this particular trial, which showed that Lopinavir exposure is insufficient in children when you double the dose of Lopinavir, Ritonavir. So we've known for many years that rifampicin reduces Lopinavir in the blood, and the easy solution has been to double the dose of the Lopinavir, Ritonavir. We're all aware that you can boost with Ritonavir, but Ritonavir is difficult to get hold of. It expires very, very quickly. It tastes absolutely terribly, and so it was just much simpler. Let's just double the dose of the Lopinavir, Ritonavir. But in this particular study, which was done in smaller children and younger children, it was found that it's not good enough, and that the priority needs to be boosting with Kaletra, and it's only when you're boosting with Ritonavir And it's only when you cannot get hold of ritonavir that you would consider double dosing the Kaletra, and preferably for a shorter period of time as possible. What you never, ever, ever want to do is give unboosted Lopinavir ritonavir to a child who is on TB treatment. So the idea is that you want to make sure there's equal Lopinavir and ritonavir in the dosing, so you can do a calculation. The easiest is just to use your dosing chart. It will tell you exactly how much extra ritonavir you need to give, and you need to boost until 2 weeks after the TB treatment has stopped. The second scenario we want to discuss is HIV and epilepsy. And very simple, there's only one drug that we can really use very easily and safely with our ARVs, and that is epilim sodium valproate. So if you've got a child diagnosed with epilepsy or develops fits, you're going to be using epilim as your first choice. And your second line drug, which you might add in if the epilim is not able to control the fits, is lamotrigine. All other anti-epileptic drugs drastically influence the blood levels of all the ARVs, and the Efavirenz can also affect the anti-epileptic drugs, so they're all contraindicated. Our third scenario is post-exposure prophylaxis. For children, we are still using AZT, 3TC, and Lopinavir ritonavir, the three drugs after acute sexual assault in children. In your older children, as soon as they're over 15, it's probably best to use your Tenofovir 3TC backbone, which one can combine with Lopinavir ritonavir, because the AZT does cause quite a bit of side effects. Another drug that's great to use is the D4T instead of zidovudine. You're only going to use it for a short period of time. It's got much less side effects in that first 28 days than AZT does, and you don't have the risk of bone marrow suppression. Monitoring of our children on ARVs is very similar to adults. Just note there that the cholesterol and triglycerides is done at baseline and then annually. Our viral load, again, done at initiation, after 6 months, then at 1 year, and then annually. In this particular one, it says that the CD4 countdown is done annually. It actually now specifies in the guideline it's done annually if clinically indicated. So you do the initiation at 12 months, and then if clinically indicated, you can repeat the CD4 as needed. The ALT is only recommended if the child is on TB treatment as well as ARVs. One of our greatest challenges with Paediatric ART is the fact that we do not have enough great formulations for children than for adults. We still have this very unpalatable Kaletra, and it's quite often in very large volumes, some of the solutions and syrups that you are giving. There's a lot of things we don't yet know about the long-term toxicities in children, and neonatal treatment has been a huge challenge. We urgently need formulations that will maximize adherence and minimize toxicity, and try and find more and more fixed dose combinations that we can use for these children. A last quick slide has to be about adherence. There will be separate lectures specific around adherence in children and disclosure in children, because it does not help us coming up with all our wonderful fancy ARV regimes and the children are not getting the treatment. And unfortunately with children, their ability to get the treatment is directly related to their social circumstances, because they are reliant on responsible adults looking after them. And this is one of the great challenges of looking after children with HIV. Thank you very much to Wits RHI and South to South for the slides, and Dr. Harsha Lohan, who's doing our clinical governance. Do make sure you've also seen our module on HIV testing to complete this specific session of the Wits RHI course.